Welcome, everyone. I am so excited to see so many of you here. Welcome to our second weekly bariatric virtual support group session. So I'm excited to have you here. I know many of you already. My name's Colleen Tewksbury. I'm the bariatric program manager. I'm a dietitian by training, and I'm very excited that you're joining us this afternoon. This will be a really special session and hopefully a good break in your weekday to be able to give you a chance to ask some questions, maybe learn something new, chat with others, and hopefully be able to get some additional information and have some of your questions answered. So how today is going to work. We will start out with a few brief announcements. I'll go over how this all functions and how the Q&A is functioning and the chat function as well. We'll do some introductions and then we'll dive into posing some questions to Dr. Dumon. Wonderful to have so many people here and to see so many individuals starting to filter in some Q&A chat hellos to everyone. We have a lot of people that are immediately post-op, some pre-op, and it looks like a few that are further out as well. So part of the reason why this is structured in this way, we will be using Microsoft Teams, and as we go along, we're going to try and make this more and more interactive. We don't have the ability from a security or a safety standpoint to do a group video chat. We've had requests for that previously. Unfortunately, that poses a lot of security issues. So we are using this platform to help protect your information and keep your info confidential, while at the same time trying to provide you with some additional support throughout this process. We're in different times and we are trying to adjust as we go. So as we progress, if you have any feedback, we'd love to hear it. If you have specific requests in terms of topics or speakers, please let me know. Either you can reach out via my Penn Medicine, you can message me here, or you can always pick up the phone and give us a call. Any of them are perfectly fine, and this is meant to be your time and to help support you. So please feel free to let us know if there's anything that we can do to help provide that. So with that, we have you all introducing yourself now, which is lovely and wonderful. Feel free in that Q&A, if you have a reply to someone, you can reply back to them as well, not directly to their post, but you can post a new question, but we're considering it a chat to reply to others as well. So if you have any questions for Dr. Dumon as I introduce him, please type them into the Q&A box. So I'll be monitoring this as we go. And so we have with us today Dr. Dumon. So let me pull up his info here. All right, so Dr. Dumon is an associate professor of surgery with Penn Medicine. Dr. Dumon started with Penn back in 1998 as a surgical resident and never left us. He has worked his way up to an associate professor, and we are excited to have him on the team, of course, and leading our PCAM location, and also sees patients at Valley Forge. Many of you may already see him regularly, but we're excited to be able to get to ask him a few questions and pick his brain. So I'm going to switch things over here for Dr. Dumon on the camera here. Welcome. We're excited to have you here.
Thank you, Colleen. Great to be with the group here. It's been an honor to be at the institution, and been an honor to work in bariatric surgery for a long time period. I think it's a very exciting field because I think it's been an underserved area in medicine. It's never been truly considered deeply in a lot of the medical fields, but I think with our bariatric program, we really try to bring, weight control, weight issues, weight management, healthy eating, in the forefront of, a comprehensive medical treatment. So that's been a very exciting journey. Also been exciting to work with Colleen and Dr. Williams and, all of my other wonderful staff here at this institution. So does anybody has any questions for me or anything that's you'd like some feedback on, or have some, things we can talk about during this time period?
Yeah. So first, Dr. Dumon, on the side chat, we have a few individuals that are saying thank you to you, or that they're a patient of yours. One, Cecily called you Superman Dr. D. So we a lot of appreciation happening for you in the chat box right now. So one of the questions that we have here is around COVID. So we discussed this a little bit with Dr. Williams last week, but interested to hear for your practice as well. What are some of the things that COVID has changed for you in bariatric surgery and the way that you practice and approach bariatric surgery?
All right, I think the number one thing, just from a practical perspective, is virtual meetings, virtual visits. I think the virtual visit actually, brings out the point that it's a lot of strain on patients to come in for, recurrent visits, once a month visits. I think you would potentially lose an entire day doing that. Now with the current telehealth visits, I think it is easier to comply and it's easier to, have an appointment. So I think that's a benefit. We want to keep it personal. So despite the fact that we have these virtual visits, I think it's important that some people can come in person, because if you feel that you benefit more from an in-person visit, you always have that availability. I myself like the virtual visits a lot because I think it's a nice way to connect with patients. From a clinical practice perspective, I think, the COVID epidemic brings out, again, unfortunately, the reality that obesity is a real health issue. I think obese individuals are definitely at risk of having a more adverse outcome if they contract COVID infections. We have definitely maintained very safe practices within our group. I don't think we have any case so far of a patient contracting COVID during their time period, and we've been able to maintain our current practice, current volume, doing the surgeries while maintaining safety during the entire hospital stay. So I think, again, COVID is probably going to bring out the fact that obesity is a real health issue. If we can treat obesity now, we can prevent other diseases from occurring. We can definitely positively influence COVID infections in patients that underwent weight loss surgery. And I'm not aware of any adverse events we've noticed related to the COVID epidemic. I've treated patients that had previous COVID infections. It can be burdensome because we have to wait until the patients are COVID negative, but once they're COVID negative and you do the surgery, I've not seen any negative effects on them. Is that your experience as well, Colleen?
It has been. And I think this is a brand new world for most of us working in this field. Actually, we're learning a lot more about infectious disease as we move forward and how to best approach things. So I think we've come a long way and have been working really hard to keep everyone safe during this time. So we're having a few different questions for you, Dr. Dumon, around plateaus and what to do if you're struggling. So what do you recommend for someone who's after surgery who may be struggling at this point?
Identify the time, don't wait. So basically, number one, be realistic in your expectation. So one aspect that I've been thinking about, and I just, my thinking on this gets influenced with recent patient experiences. one very recent patient experience is, what is considered normal weight? Typically when we provide our information session, we talk about normal BMIs, BMI of 25, around 25. Maybe it's 26, 27, but around 25. And we use that as a benchmark to identify obesity. Now, when an individual comes in and says, what is my normal weight? We still use that 25 benchmark, and we say, well, you'll probably lose about 60% of your excess weight. That's an enormous amount of weight. Often that keeps the patient on a higher side, so you typically don't become completely normal weight after weight loss surgery. Now, the typical weight loss curve progresses over 18 months. So from the day of surgery until 18 months of surgery, the expectation is that you lose weight. And if you don't lose weight during that time period, or you're stagnating, reach out to us, typically with small interventions that, you may not have recognized yourself. Oh, you kind of, maybe you creeped up a little bit on your caloric intake in beverages. Maybe, you've introduced more carbohydrates than needed. If you can make those small corrections during that 18-month time period, typically we can help you. At 18 months, it's typically you're at your lowest point. If after 18 months, you see your weight go up a little bit, 5%, a couple of pounds weight loss, that's expected. If you look at all of the curves, they all show progressive weight loss until 18 months, and at 18 months you have that lowest point, and then you're going to go up a little bit. That's expected. But if you feel that the weight loss is more than you want it to be, early intervention, and Colleen and I have spoken about this, is probably the key. And there are options. So we live in a time period that we actually have options. We have very good medical, so the first line of defense is we critically looking at diet, exercise, behavioral aspects of where you are. The second line of defense is considering medical weight management. Is there anything we can do with medication to intervene at that time point early on to prevent stagnation? Number three, if you had a sleeve, there are options for revision. If you had a bypass, there are options for revision. Putting in mind that the revision outcomes are not as great as the primary intervention. And I think the most important aspect is the bigger view, the bigger picture. The bigger picture is that this is a lifelong commitment. So you probably had some bumps before surgery, where you had some losing weight, gaining weight. You're going to have some bumps after the surgery where you're going to lose some weight, gain some weight. So don't blame yourself. Reach out early. Look at the time horizon. Don't expect changes to happen very fast at that time point, but there are interventions that we can address. And I think with this three-pronged approach, behavioral, diet, medical, and surgical, I think among those three, we can help you.
Excellent. Thank you, Dr. Dumon. And on that note, if you don't mind, well, it sounds like the primary message is pick up the phone and call us.
Yes, that's the primary message. Yes. The secondary message is don't panic. There's a lot of patients that have a little bit of weight regain, and weight regain is expected. But don't say, okay, it's fine, I just have weight regain, I'll be okay. I'll wait to call. It's better to intervene earlier. And then the third message is the timeline, with weight regain is typically not a very fast timeline. Give yourself a longer timeline to address it. And the fourth message is don't blame yourself. I mean, this is not, well, I did something wrong, or I shouldn't call, or, they won't want to hear about this, or, it's something I did. It's typically, that's why we have this entire field, right? Because it really is not related to self-induced weight gain. It is a health issue that we can help with professionally.
Excellent, thank you. And on that note, if you don't mind me sharing, one thing that the dietitians talk about often is what are the 4 top predictors of someone really doing well long term. So we had a question from Kara on here about what are some of the ways that you can really set yourself up for long-term success. So the top predictors of someone doing well long-term with weight management after surgery is 1, staying active, high levels of activity. 2, keeping track of weight, of what you're eating, having some form of self-monitoring. And 3, keeping up with appointments, staying engaged with your treatment team. And 4 is actually avoiding grazing and picking on food throughout the day. Those are all some of the items that we know can help with long-term keeping off weight and achieving weight loss goals. So we also had a question here about a hiatal hernia. So what do you typically do if a patient has a hiatal hernia and they're coming to you for bariatric surgery? How does that change your decision making? Okay,
very good question. So I am very careful with hiatal hernia. So a lot of patients have, so first of all, as Colleen pointed out to me, there was just a recent publication in one of the major medical journals that kind of shows how the quality and the outcomes of bariatric surgery, even over the last 10 years, have improved dramatically. And a lot of it is related to working up patients prior to surgery. So really, as Colleen mentioned, I've been with this institution since '98, and I've seen it evolve as far as preoperative workup, where we initially didn't have an extensive workup, and now we go to a way more intensive workup. Very often, small hiatal hernias are identified on an upper GI study or on a CAT scan prior to surgery. The first question I have in that setting is it a symptomatic hiatal hernia or is it an incidental finding? If it's a incidental finding and there are no symptoms related to the hiatal hernia, such as significant acid reflux disease, there's typically not a lot of reasons to address the hiatal hernia. I view the GE junction, the location between the chest and the abdomen, where the esophagus goes into the stomach, that is a dynamic region. It's not a fixed region that doesn't move. It's a very dynamic region. When the esophagus contracts, you want that cardiac portion of the stomach to be able to slide up and down so you don't prevent swallowing disorders. I've unfortunately seen, and I've treated a lot of patients that had hiatal hernia repairs with good intent by surgeons at the time point of sleeve gastrectomy that led to significant swallowing disorders. So I try to really identify whether the hiatal hernia is symptomatic or not symptomatic. If the hiatal hernia is an incidental finding with no symptoms, the patient doesn't have significant acid reflux, I try to evaluate the hiatal hernia at the time of surgery, and if what's confirmed in the pre-op studies is also confirmed at the time of surgery, I do not place extra stitches at that location because it's probably a natural evolution that doesn't need surgery and it wouldn't benefit the patient from doing it. If on the other hand, the patient has a significant hiatal hernia with a significant portion of the stomach in the chest and has completed the workup, or I will complete the workup, I will get a manometry, that is, pressure measurements in the esophagus. I will get a 24-hour pH study looking at acid reflux, and I'll look at an upper GI study. And if those 3 studies confirm that there is a significant hiatal hernia that is clinically relevant, I may change my operative strategy. Sometimes I close the hiatal hernia and perform a gastric bypass in those patients to reduce acid reflux disease at the time of surgery. But again, most patients with small hiatal hernias that are not significant, that don't have a clinical impact, and if the complete workup doesn't suggest anything other, then leaving a hiatal hernia in place as you do a sleeve is typically the best strategy.
Excellent. Thank you, Dr. Dumon. So we have a similar surgical topic, and then we'll shift over to a different one. Jen is asking, how common is it to have a gallbladder removed after surgery?
Not uncommon. So not uncommon. So about 10, 15 years ago, studies were done to see whether patients would benefit from gallbladder surgery at the time point of bariatric surgery, because we know that with weight loss, when you lose weight, the composition of bile changes. All of a sudden, your distribution of the different bile acids in the bile that you produce changes, and rapid weight loss can lead to gallstone formation. There are even studies done where they give patients medication to prevent stone formation, such ursodeoxycholic acid or chenodeoxycholic acid after surgery to prevent stone formation. I would say about 5 to 10% of patients have symptomatic gallbladder disease after surgery. We typically, if you know that you have gallbladder disease, we know you have stones in the gallbladder. The stones are symptomatic. We do offer simultaneous at the time point of the sleeve or the bypass gallbladder surgery. Gallbladder surgery is not without risk. So often it still can be a judgment decision about, is it the right thing to do for this specific patient at the time point of surgery. So sometimes if you're symptomatic gallbladder disease at the time point of surgery, we know about it, we take the gallbladder out. We know that you can develop gallstones over time after surgery. So if you have symptomatic disease, again, come in and have your gallbladder removed. I actually just saw a patient today who had gallbladder surgery about 6 months out of bariatric surgery. Now, doing it delayed after bariatric surgery, whether it's sleeve or bypass, again, there's no downside to it. Typically, you're at a lower weight, your risk of complications such as PEs, DVTs are lower at that time point. And, you know, Colleen used to have a slide in the information session where it puts bariatric surgery in contrast of some other, you know, bariatric procedure in some other general surgery procedures. So it's not unreasonable to claim that gallbladder surgery has about 5 times more complications than bariatric surgery, which again, I think is a reason why we don't typically do it at the time point of surgery, and we don't do it prophylactically, because if we do it prophylactically, I think we would cause more harm than good.
Excellent, excellent. And along those lines, Liza actually asks, if someone has a lot of scar tissue from a previous surgery, especially around gallbladder removal, and an exploratory surgery, can that make the bariatric surgery more complicated?
More complicated, but not excluded. So we definitely, you know, will try to do everything we can to perform it laparoscopically. Cases like that, you know, if we know going in that there's a high likelihood for adhesion because of previous surgeries, we typically increase the time slot so that the patients before or after don't have to wait. So I typically try to schedule longer procedure times for those cases so that I can take my time gently going through adhesions. Safety is everything. So at the end of the day, if the adhesions are such that it's not safe to proceed with doing a sleeve or bypass, that is a possible outcome, but that happens very rarely. Typically, we go in, we take adhesions down carefully until we feel that we have a safe surgical field to proceed with the surgery. And conversion is also an option. It could be that we cannot do it laparoscopically and we'll have to convert to open surgery. So we have to have an honest discussion about that. So yes, it can complicate the surgery, but it doesn't exclude it. Yes, it will make the surgery more lengthy, but that doesn't mean that more time spent during the surgery is reflected in a more adverse outcome. Often taking adhesions down is just a slow, tedious process again. So I think it's important for me as a surgeon to take the time out to spend a little bit more time during the surgery to try to safely take those adhesions down.
Excellent. Okay, so we're going to keep down the line of surgical questions before we switch over to some of the other questions around behavioral items and your viewpoints on some other areas of bariatric surgery. Someone had asked here an anonymous question. You had mentioned revisions. What are the possible revision options for someone who had a sleeve gastrectomy?
Sleeve gastrectomy, I hope Colleen will write up that paper because I think that we actually have pretty good weight loss outcomes and we have pretty good functional outcomes, conversion sleeve to bypass. So now of note, I know, typically our patients are very well educated, so some of you may know this, but the original sleeve data comes out of a study that considered sleeve as a bridging procedure, doing a sleeve first and then converting the sleeve to a bypass or duodenal switch. This study goes back 15 years ago. And at that time point, the big news was, well, the patients are not coming back because they're keeping weight off and we should consider a sleeve gastrectomy. And then the data came out about the safety of the sleeve, which kind of puts the sleeve in the center of what we do as far as a primary bariatric procedure. Having said that, I've done quite a few patients that after sleeve had acid reflux, converted them to bypass, or some of them had weight stagnation and I converted them to bypass. My personal experience with those patients has been that they did very well functionally, meaning that the acid reflux typically completely or predominantly resolved. Some of them are still on a proton pump inhibitor, so it's not that they're completely off medication, but the acid reflux symptoms have resolved. And I've seen significant weight loss in that patient group. Colleen is very well versed in the bariatric literature, so maybe she can comment on this, but I've actually never seen a very good detailed study in the literature that really highlights this. So that's conversion, sleeve to bypass. I think there's a lot of options there. Bypass conversions, was that part of the question as well, Colleen?
It wasn't, but if you would like to speak on that too.
So bypass conversions have always been problematic because it's in sleeve you have a really good target that you can address. Bypass conversions, yes, you can lengthen the biliopancreatic, you can lengthen the rulum, so you can go from 100 centimeters to a 200 centimeter bypass situation. You can make the pouch smaller. Often revision of a bypass has higher complication rates, and often the long-term weight loss has never been documented. And I think there's a lot of good studies that really looked in detail at long-term outcome of revision gastric bypass. So that's a different category. So what I'm trying to say is, if a patient comes in with a sleeve and needs a revision, I feel I have a good answer to that. If a patient comes in with a bypass and needs a revision, I think I have an answer to that, but that answer is not as good. Again, as Colleen said, if you gotta kind of frame it into a comprehensive approach. Often, as surgeons, myself, I can, kind of go too fast towards additional surgery as the answer. So I think there's a benefit in critically looking at the 4 aspects that she mentioned before about behavior modification, looking into does medication help stagnating or lowering your weight, and then as a third aspect, looking at surgery. And the true combination of those 3 aspects, I think, will lead to long-term success. Anecdotally, you know, we do a lot of, not a lot, but we have a significant collaboration with Children's Hospital, and those teens typically have a little bit of a longer preoperative evaluation, and they do typically very well after the surgery as far as not too many having weight regain needing revision after the surgery, which again to me identifies or underlines the importance of that comprehensive approach, me working with Colleen and her team to combine surgery with medical weight management.
Excellent. So we have 3 final questions for you, and then we'll start to wrap things up. So I saved some good ones for you. So the first one is actually in reference to a potential, well, a collaboration that we currently have with one of our colleagues, Dr. Octavia Pickett-Blakely. We have a question here around how you approach patients who have ulcerative colitis, who undergo a sleeve gastrectomy.
All right, ulcerative colitis. Yeah, so for ulcerative colitis patients, I try to avoid any type of malabsorptive procedures because long-term they may face the need of a colectomy, subtotal colectomy, and in that setting, you know, malabsorptive states can occur. Now, it's important to understand that you can have malabsorptive symptoms that are not related to weight. So you can have a BMI, and we see that, for example, with vitamin D, right? That's a very clear example. A lot of patients are vitamin D deficient as they are morbidly obese. That also applies to other micronutrients. You can be B12 deficient, you can be iron deficient, but still be obese. So malabsorptive state is something that we kind of want to avoid in patients with ulcerative colitis, because the underlying disease process of ulcerative colitis can lead to malabsorptive state, which can lead to micronutrient deficiencies. I typically perform sleeves in these patients. They typically do very well. I've not seen any change or difference in outcome between patients with ulcerative colitis or Crohn's disease regarding long-term weight loss outcomes compared to patients without these underlying comorbid conditions. I've also not seen any increase in ulcer formation. That's always a concern. Ulcerative colitis or Crohn's disease, you could develop, or you have a higher likelihood of developing gastric or duodenal ulcers as part of the underlying disease entity, and I've just not seen that. So I think it's a very safe approach. And then the final thing is, if you undergo the sleeve gastrectomy prior to the colectomy, again, you're significantly increasing the quality and the outcome of the colectomy if that is something that you're facing down the road, because performing a subtotal colectomy in patients that have ulcerative colitis with overweight, unfortunately, has not as good of outcomes as in patients with in a lower weight category. So again, that's something we're trying to achieve.
Excellent, excellent. All right. So for this one, I can also add in a little bit from a medical weight management standpoint, but we have a question from Jen of how integral is additional exercise other than walking as a part of the overall weight loss program? Will injuries that preclude a patient from participating in strength training or cardio exercise impact overall weight loss?
Yeah, so I think the best exercise from my perspective is walking. I mean, I think I mean, it's great if you can go beyond that. But if you can, a lot of patients, they're limited in their mobility. Walking, sometimes even aquatherapy to prevent joint injuries are good initial strategies. The nice thing about walking is the repetitive nature of it. You can do it every day. You can build it into your daily schedule. It is something that you can adhere to, or you can fall back to if you were not able to be compliant. I think the problem with more excessive or more intense training exercises is that compliance is an issue. Like most people, right? So I always wondered, why does Planet Fitness charge $10 for a membership fee? That's not a lot of money. So I think the reason they do it is because the threshold to spend $10 a month on Planet Fitness is not very high. I mean, it's still $10, but it's less than $100 a month. And if you look critically at the number of members and the number of active members in most healthcare programs, the number of members is 10 times the number of the active members. Again, which to me comes back to my little world where I say, okay, if I tell a patient you have to walk, and that's something the patient can achieve and can achieve it lifelong, we've reached our goal. Again, we're not thinking about, oh, we need to lose this amount of weight over the next 3 months. No, we're just trying to create a healthy lifestyle, and I think walking can be a healthy lifestyle. If you want to go beyond walking, you want to do jogging, you want to do workouts, that's great, but protect your body, protect yourself, and don't view it as a sole mode of weight control. Unfortunately, physical activity is a big influencer of long-term outcome. So I'm thinking about physical activity that's sustainable. That's why I like walking.
Yeah, excellent. And
Dr. What is your view on that, Colleen?
Oh, yes, but thanks for...
We'll do a little bit of a political discussion here.
Sure. So physical activity is actually the strongest predictor of whether or not someone's able to keep off their weight loss long term. So if someone is not exercising while losing weight and then during weight maintenance, the likelihood they're going to be able to keep off their weight loss long term from the National Weight Control Registry is less than 1%. So what we'd like to say in counseling is that people lose weight in the kitchen, they keep it off on the sidewalk. That they both have very important roles, dietary changes and physical activity, but they play very different roles. That we don't expect someone to be able to lose weight through exercise alone, but we also don't really expect someone to be able to keep it off through diet alone. You need both to be able to move forward. Excellent. Yeah,
so where I come into that discussion is then I typically tell patients don't wait too long, with increasing your physical activity, because often they've been struggling, with weight control for a long time. They undergo surgery. All of a sudden they're starting to lose weight. They say like, okay, I've lost this weight without exercise. Why all of a sudden is that becoming an important piece? The hormonal changes, we talk a lot about the hormonal changes related to surgery, right? Ghrelin downregulation with bypass or sleep or duodenal switch. They are the strongest right after surgery. Use that time period to induce your body to a regular physical activity routine that will prevent weight regain after surgery. And again, if you build it in early on, you probably will, the rate of weight loss, it's like an exponential decay. So in the beginning, you have rapid weight loss, then the next 6 months, it slows down, and the next 6 months, it slows down a little bit more. So if you're trying to influence it at that tail at 18 months, there's not a lot you can do. If you try to influence in the first 6 months, there's probably a lot you can do with less intervention. So if you do 30 minutes walks in the first 6 months versus you start the 30-minute walks after 6 months, you'll get at a higher weight in the second scenario. In the first scenario, you'll bring your weight down to a level where you want to be easier. And in addition to that, if you maintain the 30-minute walk a day, you'll stay there.
Excellent. Excellent. Thank you. And so the last and most important question of the day, Dr. Dumon, what do you love most about your job?
I like most about my job, like days like today where you see patients after 18 months that do great. It's basically working in a really exciting field, being able to address something that's been ignored for so long, and really seeing patients back and patients telling me that they feel better, that this was the right decision for them, and that's really what I like about the job. It's like being in a field that really makes an impact, and you feel you contribute a little bit to to what we're all about. So yeah, it's a very rewarding field. I've seen, compared to other surgical outcomes, it's really a field where, as Colleen said, I've seen this evolve since '98. It's made dramatic improvements. It's been it's intellectually challenging, the things that are going on in obesity, and I think the most important piece is patient outcomes, and feeling well. At least I try to help. So yeah.
Wonderful. Thank you. We are very thankful to have you with us today, Dr. Dumon. I want to actually wrap up today with 3 different items that I want to send out your way. We did have a question from Cecily that I am going to answer and put into the chat function now. So the question is, what can your success survivors do to help bolster more favorable support from insurance companies and legislators when considering both the costs relative to the procedure and the follow-up recommendations to bariatric surgery? So there is a patient advocacy group. It's a nonprofit. It's called the Obesity Action Coalition, and I'll put the website in the announcements now. They do advocating. They have meetings. I am a part of that group, and also along with our professional organizations, we typically go down to Washington at least twice a year and to Harrisburg, since I'm a Pennsylvania resident, to advocate for legislation. So noting that weight discrimination is legal in 49 of the 50 states, and including Pennsylvania, that our state exchange programs don't currently cover bariatric surgery. Medicare doesn't cover weight loss medications, anti-obesity medications. So there's lots of areas to advocate. So if you're able to join something like the Obesity Action Coalition, they have resources for you as a patient, and then they also give you a collective opportunity to contribute and to advocate. They do have patients on their board as members, so it's a phenomenal resource, and I highly recommend it if you're able to join. Do you have any comments about the Obesity Action Coalition, Dr. Dumon, before we wrap up?
Only one comment, that I appreciate your involvement with it. I think I remember seeing you on, we have a Twitter, so for the audience, we have like a ongoing Twitter account where we highlight some of the activities of our Department of Surgery members, and I think Colleen was on one of those that showed her, at one of these meetings. And I do think, as to the question about why I like this field, in '98 when I started this was not considered mainstay of medical treatment. There was a lot of opposition within the medical community about bariatric surgery. There was a lot of, thinking that, oh, it's a cop-out, why do we offer surgery? There's other ways of losing surgery. I think through research and information that shifted. I think, Colleen can attest to this. I think like studies like the Swedish obesity study really brought weight loss surgery on the map, really changed the view of a lot of medical professions. And all of a sudden, a lot of physicians now refer patients to us. So kind of underlying that, by staying on target and staying on message and continuing to advocate for obesity as a real health problem, obesity as a treatable health problem, obesity as not a weakness, but as a health issue that we can actively address. Preventive measurements and putting resources into that, I think that's really, really important, and I've seen it change. That really kind of, as to the question why I like my job, it's nice to have seen that. A lot of that I did nothing for. It's not that I did that. It's people like, patients like Colleen, that are active in these groups. They make it work. I think there was even a time period where insurance companies were considering not even covering weight loss surgery at all. I didn't do anything for that. I was just working. But I think it's like these organized groups bringing that out, relating that message to the health insurance companies and decision makers is very, very important. And there's an enormous amount that's already been achieved, but we still have to, go to the next level. So yes.
Excellent. Thank you.